whatever I'm going to speak is about my perspective and practical approach of dealing with dengue cases in our hospital setup, in our lab. And it is not like a very major study or anything. It's just a simple observation, which I thought sharing with you all will be good. Thank you, Mindray, for giving me this opportunity. Dengue is like the lone wolf. It's very unpredictable and very dangerous. You know, lone wolves are very dangerous. So whenever there is dengue, at least in our hospitals, and I think most of the pathologists will be coming across this situation, the patient is totally alarmed, panicked, so is the clinician. And the rate of, to be on the lighter note, there are clinicians who get alarmed when you say NS1 is positive. Okay? They are the grade 4 clinicians. Then you have clinicians who get alarmed when you say the platelet is coming about 1 lakh. Then you have clinicians who get alarmed when they hear platelets are between 1 lakh to 50. And then you have the real physicians, who I call, are the grade 4 physicians who actually get alarmed when the platelet touches about 50K. But it so happens in our hospital setup, whenever there is a dengue case, you have even our team, which includes nurses and paramedical staff, they all get alarmed when there is a dengue. To such an extent, we have a patient attenders. The minute there is a dengue patient admitted, they will come along with a platelet bag. They come along with platelet bag saying that, okay, there is dengue now, you give off these platelets. So they have too much of knowledge. They're all graduated by WhatsApp universities, you know. So they enter the hospital when there is dengue positive. My son is dengue positive, so I have already bought platelets because to get ours is a tier 2 city. So we don't have many blood banks. So once they say there is a transfusion which is required, then it's a lot of hassle for the patient attenders to get these platelets. So what they do is, to be on the to be on the safer side, they walk in with platelets. So I just wanted to slowly try to understand dengue in a little more deeper way, so that we can help these patients and panicked clinicians as to how well we can support them. So as we all know, dengue is a major public health problem. It affects most of the tropical countries, and in Southeast Asia, it still remains as a very high priority, and the disease is of great importance. Now, let's just revise on our basic knowledge base regarding these dengues and platelets. Now, the classic form of this infection, you have an incubation period about 5 to 8 days, then it follows by the clinical symptoms set in, and then which is followed by fever, chills, sometimes rash, joint pains, and then after which you have a convalescent stage about 3 to 4 days. And usually, most of the times, the patient completely recovers. But there are a few atypical forms of dengue. And generally, most of the dengue does present with fever. But have you seen cases where you have classical symptoms of dengue and then your sero card sometimes does not turn out to be positive? So you also have the physicians telling, I am so sure that it is dengue, but why is your NS1 card not showing the positivity? So that is again. So what happens in these kind of situations is definitely where your simple CBC and all these parameters put together can come in really, really very handy. So, like for example, in typical dengue, you see lower platelet counts and significantly higher hematocrit. So let's quickly go through this pathogenesis of dengue. So initially there is a simple, like about anywhere between 5 to 8 days of where the mosquito bites, and then you have the viral incubation period, And then after that it reaches, this is the first symptoms come in, so the virus potentially affects and then it multiplies, and then the predominant pathogenesis over here is the antibody dependent enhancement. So this is where the macrophage eats the virion particles, and then it is a virus infected macrophage which releases NS1 over here. There's a storm of events which happen over here at that point. So NS1 is released, there are inflammatory mediators, and then it also activates natural killer cells and a whole lot of cytokine storm and all that. But this does not happen initial phase. This is the phase where initially there is an NS1 which is released. What does NS1 do? NS1 acts on these small glycocalyx receptors on the endothelial cells. What it does is it weakens this endothelial cell barrier. So there are gaps which form into this endothelial cell lining the vascular system, due to which there is a plasma leakage over here. So this is the basic mechanism that we have to understand. So understanding this, how does it show in our CBC indices? We see that there is a hemoconcentration. Hemoconcentration, look at platelet crit, right? So that you see is very higher. And at this point of time, when your platelet is actually, there is a lot of loss of fluid. That is the basic pathogenesis over here. There is a loss of fluid. That is why in dengue, you need not do any fancy treatment. All has to be done is to support the patient with fluids. That's all is required. That's all is required. You do not even give platelets. Why? Because even if you give platelets, there are two things which are going to happen over here. One, you're going to put the patient into unnecessarily volume overload. And the second thing which happens over here is, you see this mechanism where it is antibody dependent enhancement, and this is the same. Even if you're going to give platelets, probably they are also going to get attacked by these cells, and that is only going to increase the storm of activities which happen over here. And have you come across situations where clinicians, they give the platelets, okay? They are not going to listen to you when you say that no, it's actually 50,000, it's 60. They still want to give because there's so much of pressure on them by the family. And then they also call you up and ask you whether the platelet has increased. That's the next set of calls that you get. We have given so many platelets. Has the platelet increased? Sometimes you may not find a significant increase at all. Why? Because the platelets that you have given probably are undergoing the same disaster which are already experienced by the platelets inside the body. Okay? So there are a couple of activities which happen over here. Whenever there is dengue, there is bone marrow suppression. It infects. There are a lot of studies, but still they say there is nothing, there's no clear one mechanism which happens. It's like a multitude of factors which happen in dengue. One is marrow suppression, where the dengue virus infects the marrow, causes of decreased platelet production. And then there is also simultaneously there's an increased destruction of platelets. There is also this vascular leakage because I told you, and so there is a lot of loss of fluids. There is an activation of coagulation pathways leading to consumptive coagulopathy. This happens exclusively in patients who are having comorbidities. A patient with normal immunogenetic mechanisms, a patient like a healthy young child usually recovers from dengue. Whereas an older man with a lot of comorbidities is likely to go into, because of irregular epigenetic mechanisms and the way these interleukins and all these cytokine storm which are triggered, they can lead to more severe forms of dengue. And of course, a whole lot of inflammatory response which is triggered by the cytokines. So coming to the lab interpretation, practicing in a small town, in a tier 2 city where you're not having much of, maximum we have a 5-part, and then you use all your hematology basic knowledge to interpret and console the clinician and the patients. So here the platelet indices, I really find them extremely helpful in doing this, and where you have to comment upon whether the transfusion is actually required or it can be put on hold. So measurement of all these indices, platelet count, mean platelet volume, platelet distribution, large cell ratio, platelet crit, immature platelet fractions, they come in very, very handy. So to quickly look through this, mean platelet value, it is a surrogate marker of bone marrow activity. It's a beautiful thing which can be seen as a marker of production rate and platelet activation. And whenever you come across very high MPV and there is an ongoing peripheral thrombocytopenia, it means that the thrombopoiesis is effective, it is happening. Low MPV means definitely there is a bone marrow suppression. Okay. Platelet distribution width, again a very nice parameter because it increases during the platelet activation. These are these small platelets which are budding and coming out. So they have these small pseudopodia formation and swelling. And because of that, you know that there is active thrombopoiesis going on in spite of a peripheral destruction. Platelet large cell ratios, this is significantly reduced in thrombocytosis. It increases in thrombocytopenia. This large cell ratio is nothing but, when you see the graph, these are the platelets which are larger than 10 femtoliters. And when you see the large cell ratio, they are inversely proportional to the platelet count. Presently, so these are all the parameters. When you put them together, you can analyze your indices. This is like so much undervalued because when we give out the HEMET report also, we don't go into these extreme smaller details of platelet, which I feel in my lab I have made sure that these are also come on the hemogram so that the clinician understands the significance of interpreting this. So presently, this dengue virus platelet interaction has been very clearly demonstrated in consumptive coagulopathy. There are a lot of perspectives and a lot of studies based on whatever I've told you, these indices and how you can interpret them and how favorable they are to decide in a dengue patient whether you should give the platelet transfusion or you should not, whether you should put the transfusion on hold. There are a lot of studies. One of the studies which really, which I liked was Garcia and colleagues. They noticed the maximum thrombocytopenia was on the 5th day of the onset of the symptoms, which is actually very true. We come across this even in our clinical setup. They identified 3 phases: proteinuria, hypoalbuminemia, maximal cytopenia. There is also bradycardia and liver enzyme elevation, only seen in the majority of people which have dengue fever, which had hemorrhagic manifestations and thrombocytopenia. But there is no study which I came across where there is a correlation between the duration of fever and platelet count. So coming to all this, in our setup, what we have done is, when a patient has, irrespective of whether NS1 was positive or not, if the patient had a very typical clinical symptom, reduced hematocrit, reduced platelets. Most probably he had dengue. He was given only supportive care, no transfusions. Only we take the WHO standard for recovery criteria where they take it as 50,000. Only 50,000 and below we had to discuss depending on the comorbidities of the patient and tell them whether they needed platelet transfusion or not. And the minute, even if it falls below 50, it goes up to 10. And if the patient, again, when you see the MPV values and when you see the large cell ratio and look at all the other indices, and if we find out that if there is a good brisk thrombopoiesis happening and we counsel them saying there is nothing to worry, they are hemodynamically stable and they are discharged from the hospital. So, thank you. It's a very simple take on dengue. With all the limited knowledge that we know about the platelet indices and how best you can help the patients and reduce the financial burden on them and unnecessary haggling around for platelet transfusions. Thank you.